So today we have Dr. Conleth Murphy, a consultant medical oncologist based in the Bons Secours Hospital in Cork, Ireland. His treatment focus includes gynecologic and urologic malignancies, as well as breast cancer. He's also a co-founder of the Excellent Cure podcast, which focuses on health and well-being. Thanks very much for joining us today, Con.
It's a pleasure. Thank you so much for having me. It's lovely to be a guest on a podcast.
Of course. Just to kick off, can you give us a brief background of yourself and your medical background?
So I am a consultant medical oncologist, as you said. I'm based in Cork in Ireland. I'm from Roscommon originally, in the middle of the country. I have been working in oncology for 22 years this year, and I love it. I did my training in Ireland, and then I did a fellowship, as many Irish oncologists do, in Sloan Kettering Cancer Centre through an excellent bursary program that was set up by the Irish Society of Medical Oncology. And I specialized in breast cancer there, but I've also kind of other treatment areas of interest, including genitourinary malignancies and gynecologic malignancies, as you said. And I suppose my two passions in my work would probably be clinical research, so clinical trials, and teaching. I love teaching, and I've just completed a master's in health professions education through University College Cork in the last year.
Excellent, excellent. I'm always curious about MSKCC and what it does differently from other hospitals around the world. What did you learn there in the fellowship, and what did you take back to Ireland, I suppose?
I tell you what it gives you as opposed to the training. I mean, I worked in my training in Ireland. I worked with some amazing oncologists, and I would say Irish medical oncologists are among the best in the world, myself excluded, obviously. But what you get with somewhere like Sloan Kettering Cancer Centre is scalability. I mean, the scale of the procedures there is absolutely unbelievable. It's an entire hospital which is completely devoted to cancer. So all the other specialties that work in Sloan Kettering, like cardiology and so on, are as a function of oncology. They're there in support of oncology, which in the opinion of most oncologists is the way that every hospital should be run. If we all could have just cardiology at our beck and call in our own hospitals, that would be wonderful. But I mean, it was just a phenomenal experience. At the time that I was training there was probably about 30 consultant medical oncologists in Ireland, and probably in the breast care unit in Sloan Kettering, there was probably about 18 or 20 medical oncologists who were just completely devoted to breast cancer.
Oh, wow.
So you had this huge degree of experience, and then you had access to clinical trials. That was the other thing, So, for example, in the breast care unit, you would have one oncologist who really just was involved in HER2 positive breast cancer clinical trials, and one oncologist who was dealing with triple negative breast cancer clinical trials. And often they were in competition with each other. If there might be 3 potential clinical trial options available for somebody with HER2 positive cancer, and there was a question of, well, which one are we going to go for? Whereas in Ireland still, we still have a situation where for many patients, there isn't a good clinical trial option available for them anywhere in the country.
Yeah,
their specific disease setting. So that was one thing. And the other thing was just the opportunity, during your lunch hour, you could go and hear an educational talk by a world expert, somebody who is just at the forefront of knowledge in this area. And every lunchtime you could do that. And then 2 hours later, you could go to another talk if you were free, so it was amazing. And the guy I worked with in the genitourinary and testicular cancer, George Boswell, was one of the forefathers of testicular cancer research globally. So when he'd see a patient, he'd say, well, you should look at this trial that we ran. And he's talking about this huge trial that is quoted all the time. But he actually wrote the trial. He accrued the patients to the trial. He knew everything inside out. So it was just such a pleasure to be exposed to that kind of knowledge and learning.
Yeah, I can imagine. It sounds pretty amazing. And just going back a bit, what led you to medicine? Why did you decide to pursue a career in medicine and specifically oncology, I guess?
Well, I tell you, medicine, I wasn't one of those people who had a burning desire to be a doctor from when I was a child. Neither of my parents were doctors. My older sister did do medicine, actually. But what I really wanted to do was go to university in Galway. So I have 5 older siblings, all of whom went to university in Galway. And I knew it was a wonderful place to go to college. And I knew I'd have a great experience there. And at the time, I was particularly interested in drawing. I'm still very interested in art and drawing, and I loved mechanical drawing in school. So architecture was very high up on the list for me, but you couldn't do architecture in Galway at the time. So when I was putting out my choices on the application form for university, number 1 was medicine in Galway, because of the options that were available in Galway, medicine was the one that interested me most. But number 2 and 3 were architecture in Dublin. So It wasn't that I was completely wed to the idea of doing medicine. And I think that equally I could have been very happy in a career in architecture if that had been the option that I had gone down at that point in time. But I actually am very glad that I did medicine subsequently, and I've loved doing medicine. And I think in some ways, not having been somebody who was at 5 and 6 years old saying, I need to be a doctor, I want to be a doctor, may have helped me. I think sometimes those people maybe have unrealistic expectations of what medicine is like, and they maybe go into it for the wrong reasons. If you have a parent who's a doctor who's really encouraging you down that road, sometimes there could be a real sense of failure if it didn't work out for you. Whereas, me going into medicine, I wasn't that wed to it. So if it hadn't been the right thing for me, I think I could have said, okay, this isn't right for me. I'm gonna try something else. But happily and luckily, it turned out to be the right thing for me. Now, I have an identical twin brother who is very like me in many ways and very different from me in other ways. But, one thing that we agreed was that we weren't going to do the same course in college. So he ended up going down a completely different route, and he went into arts, and he did English and French, and then he did a master's in literature and publishing, and ultimately went down the IT route. Actually, he's an IT specialist now. But I think we all have different careers within us. And I think equally he could have ended up doing what I do, and maybe I could have ended up doing what he does. I'm not sure. When he tries to describe his job, I find it very hard to understand what he's talking about. But oncology then was a much easier kind of decision for me, because it was my first senior house officer or SHO job was in medical oncology. And it was in St. James's Hospital in Dublin. It was an amazing department, and I had amazing mentors there. And I think that really influenced my decision to go down that route. So my mentors there were not just consultants, but also one of the registrars who was there at the time was a real influence on me as well. And I saw the quality of care that was being delivered to people, and the amount of attention to detail that was being given, not just to the cancer care, but to everything else that went with it. And I said, this is something that I want to do. So I quickly decided after that first SHO job that I wanted to go down the medical oncology route. And I ended up staying on there as a registrar, and then applying for the specialist registrar program after that.
Okay, very good, very good. And bringing it to present day, what do you think are some of the biggest challenges at the moment in oncology?
Oh wow, there's a few. The biggest challenge for me is trying to keep up to date. It's just incredible. I mean, it was one of the things that attracted me to medical oncology was how fast moving it is. And if you look at the landscape of treatments that we administer now compared to 20 years ago or 21 years ago when I was that first year SHO, it's phenomenally different. We've gone from mainly prescribing cytotoxic chemotherapy to having all of these targeted therapies and monoclonal antibodies and antibody-drug conjugates and so on. But trying to keep up to date with the developments and the pace of change across not just one specialty or one subtype, one disease area, but a number of disease areas is really challenging, which is why it's, there has been such a huge push to have people kind of subspecialize. When I was originally qualified, everybody treated everything. And, you treated breast cancer, you treated lung cancer, you treated colon cancer, you treated prostate cancer. And it's just not possible now. And even when I've narrowed down to 3 kind of disease areas that I tend to treat, trying to keep up with them is really challenging. I think possibly the other thing is trying to meet people's expectations. So there's a lot of cancer is in the news all the time, and there are major progress being made in certain areas, and unfortunately in other areas we are lagging behind, and there's still a lot of ground to be made up to try and improve treatment options, and just sometimes trying to manage people's expectations when they have a disease where there are limited treatment options can be a challenge. And the third one, I suppose, for us would be, realizing when a new technological development is appropriate for use in a particular patient or patient group. So sometimes our ability to test for mutations, for example, outstrips our ability to match that to treatments. And, oncologists can be as easily distracted by shiny new things as anybody else. So sometimes we can be really distracted by, well, this test is available, so therefore we must use it. But if it's not going to change things for that particular patient, or if it's not evidence-based, I think we have to be really careful about how quickly we adapt it. So it's just a constant lesson to ourselves to really look at the evidence and sift through the evidence and say, okay, does the data that's out there, do the data that are out there support the adoption of this in clinical practice?
Okay. When you say keep it up to date, do you mean like the newest treatment for breast cancer for, is it HER2 positive or,
Yeah.
Is it that kind of thing? Just understanding what's there. And
even just in breast cancer, in the last year, we've made huge advances. But there are new treatments that are available in HER2 positive breast cancer. There are new treatments that are available in triple negative breast cancer. There are new endocrine therapy options. There are nuances in the way that we use those treatments in particular settings. So I spoke at the gathering on cancer recently, which is an annual event. You're familiar with it, that is organized in Ireland, where we have Irish speakers and invited speakers talking. So I spoke about triple negative breast cancer, but I stayed to listen to my colleagues' talks about HER2 positive breast cancer and ER positive breast cancer, and just the nuances that are there are just phenomenal. And then you go and try and keep abreast with prostate cancer and the nuances of different treatments and different tests that are available, and then bladder cancer, and then testicular cancer, and ovarian cancer, and cervical cancer. It's huge. And the rate of release of new data is increasing all the time. It's like a snowball sometimes rolling down a hill. It's picking up pace all the time, and you just have to really be on the lookout for what is relevant and what is practice changing.
Yeah, of course. Yeah, very, very interesting. Yeah, I'm trying to think of like what we could do from an Onco Assist perspective in that regard.
Well, I think Onco Assist has been really helpful. I think it's such a great tool in terms of the different. I love the way that you have the common toxicity criteria there at my fingertip. Whenever I have students with me, I'm like, okay, this is a very important tool that we use in oncology. We use it for patients on clinical trials, but we should use it for everybody. And if you can master this terminology, then you're so far along the road to understanding what's important. And I use your immunotherapy toxicity tool all the time. They're all really important. I think that's important. But one thing I have missed this last couple of years has been traveling to conferences.
Oh, of course, yeah.
And I know you spend a lot of time in the airport and a lot of time in the airplane and traveling to the airport, and you say, oh my God, it's such a waste of time. But actually, when you get to a meeting, actually immersing yourself in the meeting and being there and saying, right, I'm here, I might as well turn up to all of these lectures, and then grabbing coffee with somebody afterwards and saying, what did you think of this? And that's so important, that human connection.
Of course, yeah. It the digital doesn't do it really. Like the online version doesn't quite cut it, in my opinion, anyway. No. What would you say excites you most about oncology at present? Like, what do you see coming down the line that really think will be game changing?
Well, I suppose the one of the most exciting things for me at the moment are the antibody drug conjugates. I think they have been so exciting over the last year or two. So, I mean, one of the first ones to become routinely available for solid tumors was Kadcyla, which is trastuzumab emtansine. So it's the Herceptin molecule antibody bound to a potent chemotherapy drug. And that really revolutionized the treatment of HER2-positive breast cancer. And then this new antibody drug conjugate comes along, trastuzumab deruxtecan, which in the Destiny studies blew Kadcyla or trastuzumab emtansine out of the water. It was phenomenal, and it's so active. And we're using that at present in Ireland on a compassionate access scheme. And I, have had personal experience. I have a lady who has metastatic breast cancer extensively involving her chest wall, which was really very distressing for her. As you can imagine, every time she looks down at her chest, she can see this cancer extending along her chest wall. And we treated her with an HER2, and I have the photos of her skin of her chest wall on her first treatment, and again repeated 3 weeks later on her second treatment, and virtually normalized. Wow. It's amazing. Now, that's one patient, but the clinical trial data backs up this as a very active drug. And what's nice about the antibody drug conjugates is they get that little bit closer to what Paul Ehrlich was describing way back in the early 20th century as the ideal anti-cancer drug, as being a magic bullet that delivers the treatment to the cancer cell without damaging other cells. So, there's a delivery of the chemotherapy payload to the cancer cell, and theoretically less toxicity in general. And actually that's borne out in some of the studies where antibody drug conjugates are compared to conventional chemotherapy, and you see lower rates of toxicity. Of course, there's no such thing as the perfect anti-cancer therapy, and they do have their own side effects, and particularly pneumonitis that you have to look out for. But they are very promising. We've been lucky enough to work over the past number of years in ovarian cancer with a very interesting antibody drug conjugate called mirvetuximab soravtansine. And in my hospital and in the country, we have taken part in a number of clinical trials with this agent. And it's been really interesting to be involved in the developmental process with that drug as well. Excellent.
Very cool. And why did you decide to start the Cure podcast? It's obviously a step away from oncology a little, but I'm very curious as to what led you to set it up. And
in one word, my co-host, Dinny. So myself and Dinny, who set up the podcast with me, we have been friends for a number of years. And I mentioned to you before that we bonded over a love of coffee. We both love coffee, and we particularly love very pretentious coffee, as pretentious as possible. So we were in San Francisco at a meeting, and we went to a coffee house, and we had this siphon coffee, which is it's a big production, and they give you tasting notes beforehand, and it takes about 15 or 20 minutes before you sip it, and then it's kind of cold when you sip it. But anyway, we were chatting, and he's quite different to me. So he's a medical representative, but he doesn't have a medical background himself. He's very sporty. He's a hurler, and he's very interested in supplements. He takes X, Y, and Z supplement, creatine. Yeah. So we were debating and arguing essentially about the pros and cons of supplements and various different things. And somebody said to him, he said, yourself and Con should do a podcast together, and kind of talk about these things. And he said it to me, and I said, oh yeah, of course. Thinking that he would forget about it. I'd love to imagine these things and to dream about these things. And I said, no problem, we'll do a podcast. And then we came back to Ireland, and then he kept messaging me, and he said, okay, I bought the microphone. He said, this is the microphone you have to get. He said, when are we recording our first show? And then he downloaded the software to do it. And eventually I stopped taking his phone calls for a while, but he kept ringing. So eventually he wore me down. And of course I see the negative in things. I'm really cautious, so I was like, well, what if we do it and everybody hates it? Or what if we do it and nobody listens to us, and then we'll be ashamed forever or whatever. And he said, just do it. So we recorded an episode which was a practice run, and it wasn't supposed to be released. And then he released it the next day. So
I think I listened to that one. Is that the very first one?
Yeah, and I sound like I'm down a well. Yeah. So he wasn't supposed to release that one. So he released that one, and then we were kind of committed to it after that. So and it got easier and easier the more we did. And it's actually it's so lovely because, as you said, it's a complete step away from my day job. And we deliberately are not focusing on cancer in the podcast, although actually it has helped a lot in some of my interactions with my patients with cancer. I've often said to them, have a listen to this episode. If you're sleeping very poorly, we did an episode of a podcast on this, have a listen to this. Or, one of our guests, Kieran Fairman, who's an exercise physiologist, he spoke a little bit about exercise physiology and cancer. And I've often spoken about it to my men with prostate cancer, for example. But we were deliberately aiming at not at either the medical community or at patients with cancer, but just at everybody. I was interested in the people we had on for my sake. Dinny was interested in them for his sake. And we wanted anybody who has an interest in feeling a little bit better, non-pharmacologic, I stress, ways to make yourself feel better and live a little bit better. That's who we aimed for.
Okay. And what would be your key takeaways from the interviews you've done so far? Is there anything like you've implemented into your life?
Oh, so much I've implemented into my life. I think, we've interviewed lots of different people. We've covered different topics. We've covered diet. We've covered the gut microbiome, a guy from Roscommon who's a professor in UCC who was fantastic. We did a fair bit about exercise. We did sleep. We did grief, was really interesting. We did teamwork and coaching. I guess we often talk about this. The take-home points, we always ask our guests, we say, okay, we're called the Cure podcast because we're trying to give people little cures. We're not trying to cure any major ailment, but we're trying to give people little cures for modern life. And we always ask our guests for simple tips for people. And they're always simple, and they always apologize. They're always really apologetic, and they say, oh, I'm so sorry, this is going to sound so basic. And they're often basic, and they're things that we all know, but it's great to have it reinforced. Sleep is so important. Eating a balanced diet without without over obsessing about calorie counting, but eating a rainbow plate, avoiding processed foods. Fermented foods are great, and I do drink kefir every day now, or kefir.
I got it as well.
And I have my little culture going all the time, and myself and my wife both take it, and that's been a really simple thing that we've done. And I think one of my very favorite guests that we had on recently was a dietitian who works with me, actually, who is like many of our guests. He's super smart, but he wears it lightly, which is always a lovely trait in somebody. And he talked about self-compassion, radical self-compassion. And I thought that was fantastic. He approaches every patient that he sees as an individual, and he doesn't try and give them, okay, this is your printed out card of what you must eat, because he looks at their background and their socialization around food and their mental concepts of food and so on, and he kind of tailors the recommendations to them. And he always says, you can't have compassion for somebody else if you don't have compassion for yourself. So that's been one that I'm trying to work on. Probably the sleep is the one that eludes me the most.
Yeah. I've two young kids, so I definitely I've been avoiding that episode because all I read about is like the side effects of bad sleep all the time, and when you have young kids, it's hard to get good sleep.
Yeah, absolutely. But then you practice radical self-compassion.
Yeah, of course. Yeah, that makes up for it. Yeah.
We had a good parenting one as well. We had a great parenting one as well.
Very good.
He was amazing because he spoke. Coleman Nocter's his name. He's a child psychologist, and he spoke really well about building self-esteem in children and the difference between self-confidence and self-esteem. It was really good, and particularly with all the challenges that children and teenagers have faced since lockdown, since COVID and since the lockdowns. That was really good. And I suppose Dinny is probably at the same phase in his parenting life as you are. So he has two twins who are just toddlers now, whereas my children are older. Dara is 9 and Juliet is 13. So, but Coleman had advice for both of us really on kind of dealing with the challenges, because the challenges keep coming, I'm afraid to say, Kevin.
Yeah. Doesn't get easier. You might start sleeping, but other problems arise.
Correct.
Is that one live? Is that on?
That's out. Yeah. That's from season 2. That's from season 2. So we've recorded about 6 or 7 episodes, maybe in season 2, and we've taken a little break over the Christmas, but we're due to start recording again soon.
Okay. And how often do you interview people? Is it once a month, once every 2 weeks, or does it depend?
In general, when we're releasing, we've tried to release once a week when the season starts, but it can be quite challenging, actually.
Of course.
So we've taken a little pause at the moment, but we'll probably start up and aim to start going once a week again. We often do kind of a glut of interviews at a time, where we might be interviewing somebody on a Tuesday evening and on a Wednesday evening and on a Sunday evening. And then we've got a little bit kind of stored up for the future, particularly if we know in either of our work lives or our personal lives, things are going to be really busy for a while.
Yeah, of course.
Which is often the case. Yeah.
Is there anyone you're particularly looking forward to interviewing?
I tell you, I'll tell you who my dream interviewee would be. There's a guy called Michael Pollan, who's a nutritional expert, and he's the guy. He came up with the mantra. I hope I say it correctly now. He says, "Eat well, mainly plants, not too much." I think that's what he says. So very simple advice, but a very intelligent man. So he wrote a book recently about natural pharmaceuticals and their impact on human society, and one of the sections of the book was on caffeine, and he wrote all about the history of caffeine and the coffee houses in London and how they facilitated intellectual debate and were the centers for a lot of thought movements that became very important in modern society, and the effect that caffeine has on your brain and on your body. And I would love, seeing as we bonded, myself and Dinny bonded over a love of coffee, I would love to have him on. He would be my ideal guest.
Okay, very good.
But I must say, the guests who surprised me are the ones where I felt, oh my God, I'm not going to have anything to contribute to this conversation, So as I said, Dinny is big into sport, and he is he's a hurler and so on. Whereas team sport was something, I have terrible hand-eye coordination and foot-eye coordination and hand-foot coordination. The only good coordination I have is foot-mouth coordination, because I always put my foot in my mouth. But so I never considered myself as a sporty person, although now that has changed. I've actually become much more active as I've got older, into my 30s and 40s. I've got much more active. So now I do consider myself to be an active person, if not a coordinated person. But there have been some people on. So we had Ian McKinley, who's a rugby player who had a devastating eye injury in his early 20s and had to give up rugby, and then developed, along with his brother and some academics, developed these goggles to help him play rugby again, and ended up playing for Italy. A fascinating guy. So I would never have come across him really in ordinary life, but Diddy said, look, he's got this documentary on Netflix, you should watch it, it's amazing. And then he contacted him, and Ian came on to speak to us, and it was just one of the most incredible hours talking to him, listening to his story. I'm so happy that we've had an opportunity to meet people like this and to have these conversations that I never would have had otherwise. And particularly when we were going through lockdowns and so on, and the pubs were shut and so on, I said, it's like our weekly visit to the pub, but we're meeting somebody different every week, and we're, having such a fascinating conversation.
Yeah, of course. Yeah. I have to say, like, the ones I've listened to so far have been excellent. They've been really, really good.
Fantastic.
Yeah, the professor, the guy in UCC, the micro.
Oh, John Cryan.
Yeah, he was really, really good. I've been trying to.
He's from Roscommon, so the brain power in Roscommon is amazing.
Yeah, must be something in the water there.
In the microbiome.
Yeah. Yeah, that's very good. I know Michael Pollan's big into psychedelics as well.
Yeah.
And there's some trials been run in psychedelics. There was, speaking of Netflix documentaries, I watched something over Christmas about that.
Yeah.
Have you ever, looked into that from a medical perspective?
No, I mean, I have some patients who have spoken about it. All right, I think it's fascinating. I've read a little bit about it recently in terms of work that's been done with PTSD, for example, and for very therapy-resistant depression. So I think it's definitely an area, as with so many things in medicine, the pendulum always swings, they were being investigated in the 60s and 70s. And of course, then, you had drugs like LSD that were heavily abused and so on, and it became associated with kind of the counterculture movement and the psychedelic properties of certain plants and so on were ignored for a long period of time, but it's coming back in again. It's a little bit like we had somebody on speaking about the menopause. We were harangued into doing it by our guest. They said you can't do a show in 2021, 2022 about well-being without covering the menopause. But she was amazing. She was fantastic as well. And the pendulum in medicine swung regarding hormone replacement therapy. There was a large study called the Women's Health Initiative that suggested that the risk of breast cancer was increased with hormone replacement therapy. So it was completely contraindicated or contraband for a number of decades. Whereas now the pendulum is swinging back again, and we know that there is a role for HRT. And like so many other things, it's about the nuances, and it's about considering the pros and cons, and it's about having a dialogue with your patient, discussing these are the potential benefits, these are the potential risks, and then considering it. So that was a really interesting episode as well, and one that we definitely learned a lot from.
Yeah, of course. So for any patients or caregivers listening to this, what are your tips on navigating cancer care? What would be your main advice?
Oh, I would say for caregivers, I would say it's just so important to be there for the person and to offer practical support, and sometimes it's so hard to know what to do. But if you can, if somebody's going through, for example, breast cancer chemotherapy, having somebody offered to do the laundry for them and to fold the clothes, that could be a huge thing. And it's these practical things that can be really good. Don't avoid somebody who has cancer. A lot of my patients tell me about the face that people in their community have when they have heard that you have cancer, and they put on that kind of real sympathetic face, but as they're crossing the road, and that's one of the reasons why a lot of patients like to try. We have a scalp cooler in the day ward, and a lot of people like to try to use the scalp cooler because actually keeping their hair means that they don't encounter that face, because it's such an external sign of being quote unquote unwell. For patients, I would say, try to avoid Dr. Google as much as possible. And try to avoid that neighbor, that neighbor who always wants to give the bad news, so they hear you've got cancer and they want to tell you about somebody they know who did really poorly, and the doctors could do nothing for them. They never want to come to you with the good story. No two people with cancer are alike, so you can't compare yourself to the neighbor's sister or the neighbor's aunt. Try to avoid Dr. Google. If you are going to go onto the internet, ask about information sources that are reliable. Things like Macmillan Cancer Support or the Irish Cancer Society in Ireland are useful places to get information. But equally, ask your doctor, ask your nurse that's looking after you, ask your nurse specialist. That's what we're all there for. Have a notebook, write down your questions in between your visits, because people come in and they say, oh, I knew there was something else I wanted to ask you. And I know I'll remember in the car journey home. We love being asked reasonable questions. And there's no such thing as a stupid question. So, if somebody comes in and they say, look, I've got a couple of questions for you, usually they're things that we can answer very easily. And if not, there are things that we can find out for you.
Yeah, of course. Yeah. And do you give advice about exercise and diet and stuff like that nowadays?
We do. I mean, there's a huge amount of work to be done there. The role for those kind of supportive um, uh, supportive care like nutrition and exercise is really developing, and we're more behind in Ireland, I would say, particularly with regard to exercise, than some of the big centres in the States. Again, just going back to the podcast, the interview we did with Kieran Fairman, who's the exercise physiologist, was incredible. And the work that he's doing in terms of really looking at the data and doing the research in terms of what impact exercise has in terms of real measurable outcomes in patients with cancer is fascinating. And he would be the first to say that there's a lot more work to be done, but at least it's being done now. Instead of saying, oh, well, you should probably exercise because we think it's good for you, they're really kind of coming out with the data to back it up and coming out with kind of very defined protocols that people can implement in their lives. So I think that's very useful, and there's definitely a role for all of those things. There's no point us giving chemotherapy if we're not dealing with the whole physical side effects, the psychological fallout, the social fallout from a cancer diagnosis.
Yeah. I noticed was it a couple of years ago in Australia, they started prescribing exercise as part of treatment. Everyone's treatment, it's kind of built in.
Yeah,
which I found interesting.
Well, it's when I'm talking to somebody who's finished their chemotherapy for breast cancer, and they say, okay, what can I do now going forward in terms of lifestyle? And they'll have encountered people who will say, you need to cut out all the dairy from your diet, you need to cut out all the sugar from your diet, etc., etc. I say to them, the large epidemiological studies have only shown 2 lifestyle modifications to reduce the risk of breast cancer recurrence, and those are regular exercise and low alcohol intake. So if you want to do something in your life to have an impact, those are the things to focus on.
Okay.
So,
very interesting.
And they're simple and they're straightforward. And people say, it can't just be that. I must need to take some supplement on top of it or whatever. Yeah. Now, vitamin D, I do prescribe vitamin D because we did an interesting look in our day ward a couple of years ago. We looked at vitamin D levels, 25-hydroxy vitamin D levels in patients coming in. So we're in a Northern European setting with a lot of cloud cover, as you know. And we measured the vitamin D levels across a year, and we found that virtually everybody was deficient in vitamin D when they came for their first cycle of chemotherapy. We had a brief spell of about 4 weeks of beautiful weather in kind of late July, early August, and then people started coming in with normal vitamin D levels, and then September bottomed out again. So there's some, it's relatively kind of tenuous, but there's some evidence to suggest a lower risk of breast cancer recurrence and potentially a higher efficacy of treatment if you have normal vitamin D levels. And it's a very straightforward thing to replace. So that's the one supplement that I ask people to take. Creatine is being looked at to mention.
I was just about to ask.
This is something that myself and Diddy debate all the time, whether people should take creatine supplementation or not. And spoiler alert, I have started taking creatine since
really
since the podcast. It's one supplement that I have started taking. Again, Kieran Fairman is doing research into creatine supplementation in men with prostate cancer who are taking androgen deprivation therapy, which, as he says, is like a form of accelerated aging for the body. By removing testosterone from the body, it almost accelerates the aging process in terms of loss of muscle mass, loss of bone density, increased fat deposition, and so on. So he is looking at doing the research to establish whether creatine is effective in that regard. But that's what it comes down to. We should have the same standards for complementary therapies as we do for conventional therapies. So oncology is based on randomized controlled clinical trials where really you could come up with a hypothesis and then you try to prove or disprove it. And we should have the same standards for things like nutrition, for things like supplements, for things like exercise. And thankfully, we're seeing that now.
Excellent. Brilliant. Well, yeah, that's everything, Con. Thanks very much for your time. It's been a real pleasure having you on. And yeah, I look forward to more Cure podcasts. I'll be definitely watching for new episodes.
Thank you so much. It's been a real pleasure.